Chairman, ladies and gentlemen, thank you very much for the invitation to talk about early tumor shrinkage. As you can see or will see, this is a topic that not I, but also the chairman are quite heavily involved in. And I will start with a quotation of Dr. Grossi's work, where he early on in 2008 in the JCO stated that survival in metastatic colorectal cancer was not dependent on response. And I think this was mainly due to the fact that response was categorized in terms that response was associated with complete and partial response and was differentiated from non-response patients, whereas and progressive disease patients were included. This doesn't work. Okay. So this, in fact, really relates to the concept of stable disease according to RECIST, and as you can appreciate, this includes, in my view, at least two different groups of patients, those with tumor shrinkage 0 to 29%, and those where you actually even see tumor progression. So, doesn't work. Thank you. Mrs. Sommermeyer and Emery de Gramont and many others, they performed within the ARCAD group an evaluation of nearly 12,000 patients, looking at early objective tumor response. And here you will first see that we possibly need to look at things in a different way. What you can see here is that EOTR is a strong and independent predictor of overall survival and progression-free survival. And this is looked at different time points at 6, 8, and 12 weeks according to RECIST. So the difference to what you have seen before in the Grosser paper is certainly also the time point when you look at things. Another piece of evidence comes from Zhao and co-workers, where they performed a retrospective analysis of a large phase 2/3 trial, including 468 patients evaluating therapy targeting IGF-1R. And what you can see here is that even a smaller gradation of response cutoffs in fact relates to survival, and you can differentiate aggressive partial response from stable disease patients who may be categorized as minor response patients from those patients who actually have no change, and you can again differentiate those patients from patients with progressive disease. So also this is a piece of evidence showing that the tumor response relates to survival. Now, Pierre and Suzuki and others, and also we have performed much work in the evaluation of early tumor shrinkage. Early tumor shrinkage per se is a continuous parameter, but it can be categorized by introducing a cutoff value that has been published as 10% or 20%, depending on how you look at it or which trial you include or evaluate, looking at chemotherapy alone or including also anti-EGFR agents. And you can also certainly look at different time points, 6 weeks or 8 weeks. Here you can appreciate that if we look at early tumor shrinkage, let's say at a time point of 6 to 8 weeks, we cover many more patients than we would do by a RECIST application. So what I want to show is that early tumor shrinkage in fact correlates with chemosensitivity and is associated with prolonged survival. This was work that we did in the IAO in Germany, and here you can see that the concept of early tumor shrinkage is in fact true also for chemotherapy alone. This was a pure chemotherapy trial comparing FOLFIRI versus a modified IROX regimen. And you can see a delta of, let's say, 10 months between early tumor shrinkage and non-early tumor shrinkage. You probably have seen these slides manifold. This has been shown specifically for anti-EGFR agents, and we can presently state that the addition of cetuximab to chemotherapy not only increases the amount of patients reaching early tumor shrinkage, it is also associated with a marked improvement in overall survival, which is true for the cetuximab-based therapy, but to a less extent it is certainly also true for the chemotherapy alone. This you can also see in the PRIME study, which compared FOLFOX plus minus panitumumab, and also here you can see that patients with early tumor shrinkage do far better than if they don't have early tumor shrinkage. In fact, what you can see also here is that patients not having early tumor shrinkage, they did even worse when they had panitumumab than if they had chemotherapy alone, and probably the problematic of RAS mutation is behind that. So early tumor shrinkage is helpful to make early decisions on how chemosensitive or sensitive to our targeted agents patients are. This is an advantage. In my view, early tumor shrinkage as a concept also has a severe disadvantage, and that we have a difficulty in defining non-early tumor shrinkage patients. And what you can see here is that we probably are able to differentiate minor shrinkage from progressive disease and probably also from new lesion patients. And what we did here with this chemotherapy trial, we looked at shrinkage greater than 20%, and we looked at minor shrinkage, and we looked at patients increasing with their tumor load from the starting point, and even those patients with new lesions. And I think the important message here is that patients with minor shrinkage do almost as well as those patients that we had previously categorized as shrinkage patients. So if I can sum this up, I would say the message for early tumor shrinkage patients is easy, it's clear. For non-ETS patients, it's far less clear, and we need to look at least at 3 different groups here: those with minor shrinkage, those with early progression, and those with new lesions. And I think this concept needs to be really introduced into the minds of oncologists. The next step that we did is we tried to integrate the concept of deepness of response, and I would try just shortly to explain that. We start with early tumor shrinkage. I explained that to you, and we never understood how did really early tumor shrinkage relate to survival. And we thought that the deepness of response that the patient could achieve was, in fact, probably the relation to survival, in that we could argue that early tumor shrinkage is probably the predictor of possible deepness of response in these patients. Now, in the previous talk, you have heard that progression-free survival is an interesting concept as a surrogate parameter. Here you can see in this concept that the differences in PFS are not that great if you look at patients categorized as ETS or non-ETS. However, the differences in overall survival in this concept are much, much greater. So I think for certain treatment strategies, including intensification of chemotherapy or adding anti-EGFR agents, here we need to rethink the importance of PFS, and I would rather think that the deepness of response is a better concept here as a surrogate parameter. What you can show in the OPUS and also in the CRYSTAL trial is that deepness of response is greater than when we add an anti-EGFR agent such as cetuximab to chemotherapy. And we also can show that deepness of response correlates with post-progression survival. I was very happy that Professor Mansmann did, in fact, this correlation. You see the scattergram is quite wide, and this is, in fact, due to the fact that we are looking here retrospectively at RECIST-based data, not at the whole tumor burden. I would think that if we are able to look at whole tumor burdens and specifically also tumor volumes, we get much more correlation. But this, as I was told, is already highly statistically significant. Now, where are we heading in the future? As I already indicated, in my view, tumor volume is much more interesting. Just think of a patient who has a 5-centimeter lesion and goes down to 2 centimeters. Looking at it by RECIST, you go from 100% to 40%. If you take the WHO criteria, go down to 15%. And if you use tumor volumes, you go down to 6% here. So the sensitivity of the analysis of tumor shrinkage is based on a volumetric analysis, much more interesting. And Professor Mansmann here also did this calculation showing a much steeper course of response, certainly if you look at tumor volumes. And I think that is what we are approaching. We need the technology for that, but in fact, many centers already have it, and we can do that. I don't want to leave the podium without quoting a last paper that was recently published by Laurent Claret. And I think the message here is that for different strategies of treatment, specifically anti-VEGF guided treatments. We may use different ways to also evaluate deepness of response or predictors. And what they did is they did not so much look at deepness of response. They looked at time to tumor growth, TTG, which in their analysis really captured the benefit from bevacizumab in first-line treatment. So this is another category that we may add to what I said before. Different strategies require different instruments. So I summarize and would say RECIST-based response categories are insufficient predictors of overall survival, in my view. Early tumor shrinkage is a novel instrument to predict high sensitivity to treatment. ETS may be viewed as a predictor of potential DPR. The patient does not actually need to reach it. He can reach it. He can also drop out of treatment before, but we can motivate that patient. DPR correlates with post-progression survival and overall survival, and volume-based measurements may be more accurate than longitudinal assessment according to RECIST. Thank you very much.